Hi, Madame Bégin. It's an enormous pleasure to be here, and this is such a great audience. Thank you very much for inviting me to be part of this. I'll be as brief as I can. I'm not delivering the part of this panel that you're interested in, which is basic income. I'm delivering the part of this panel, which is what else we can do with our money to actually offset costs, which is another way of putting more dollars in people's pockets, and how that might actually build solidarity. But the reason we are even talking about this is because of income inequality and how it's been rising in Canada. Well, it rose until 2000, when you look at what happened to the middle class being hollowed out. But increasingly, the two ends of the distribution are getting more disparate, particularly in our large cities. And that means people live in rich and poor neighborhoods increasingly more frequently than they did a generation ago, where we had many more middle-income neighborhoods and much more mixed-income neighborhoods. And that changes the way people experience life, because people with low income live in low-rent neighborhoods, and they're low rent for a reason. It's because they have very poor services, poor housing, poor schools, poor access to public transportation, and poor recreational facilities, and often they involve food deserts when it comes to affordable and nutritious food. So reducing health inequities isn't just about more income. Even if you give people that live in large tracts of land that are low income more money, they will still need more services. And redistributing income inequality, I would suggest, is a thought experiment. You can either give people more money, or you can actually reduce the things that make not having money a problem. And some of those things would actually build solidarity at a time when slow growth is going to mean that any kind of major redistributive process is going to make it very politically fractious for us to maintain, even if we achieved what we were looking for, very fractious and difficult to maintain it as we move into the future. So my pitch is closing the income gap is simply not enough, though believe me, I've worked for 30 years in trying to close the income gap, to reduce poverty, improve dignity, and raise bargaining power. So I'm looking at the things that permit us to do this, no matter what the mechanisms are. So the 3 points I want to make to you is that place matters, and there are ways of tackling health inequities, qua health inequities, not as an outcome of inadequacy of income, that you can fix, and that they are actually going to be cheaper fixes than an income solution. And that I want us to think about how we can move beyond reducing the income gap towards building a solidarity with one another. So we know that where you live affects your health here on this map. Toronto is the big red dot at the bottom. One of the reasons why we have less health disparities than other jurisdictions is because we have universal access to primary care. But we don't have universal access to pharmacare. We don't have universal access to things like dental, drug, and vision care. So we're good, but we're not terrific. But we know that even more in our neighborhoods in Canada, it depends on where you live. Where you live will tell you what your life expectancy is. There's a fabulous series that Hamilton's Spectator put out not long ago showing a 21-year difference in life expectancy between neighborhoods in one city. And the point is here that you could lose an entire generation between these neighborhoods, top and bottom. And it isn't, this isn't the sort of thing that is just based on income, but how people live in these neighborhoods. This is a map from David Holchansky's groundbreaking work at University of Toronto showing that over the decades where we have seen income inequality grow, we have also seen the fastest growth in our type of neighborhoods are poor neighborhoods, and the fastest decline is in middle-income neighborhoods. And if you take a look at any big city in Canada, you will find the same thing, that people are sorting themselves by income, and wherever you go to a low-income neighborhood, you find fewer access to services, worse schools. I gave you the list. So we know that one of the best ways of flattening the gradient is better housing. And we know that low-income households live in the least expensive and least desirable forms of housing, wherever that is in whatever city you're talking about. And that housing affordability, we talked about food insecurity, but a lot of people say if you fix the housing affordability problem, you fix the food insecurity problem. 60% of female lone parent renters find themselves really eating into their incomes, what income they have, because of the costs of housing. And amongst the poorest quintile, over half of them are spending more than 50% of their income on housing. So homelessness is actually, we know, cheaper to cure than to treat. We have the $1 million Marty story from the United States. I think the New York Times told that story. If you house people, this is what happens. So the blue chart is if you don't do anything. If you put housing first, this is what happens. You reduce your incidence and your amount of hospitalization. You actually improve people's health, and that's just by putting them in housing, and it costs less to fix them. And that's fixing the past. As you see at the bottom, it says for every dollar we spend on housing, we're saving 54 cents in other services. That's fixing the past, fixing the future. So the kids that Cindy Blackstock was talking about, almost 50% of children that are in low-income neighborhoods, and we're not talking about on reserve, this is off reserve, they start school not ready to learn. So we're already squandering their human potential. And we know that high school dropout rates are above 50% in many of these neighborhoods. In many of these schools, over 90% of the student base is low socioeconomic status, and that means 50% turnover. They don't even stay in the same school. And it's impossible to teach your way out of this. So a long-term solution it leads to things like inclusionary housing. We just had that legislation passed in Ontario. It'll be fascinating to watch how that changes. If we had had that in place 15 years ago, we could have harnessed the construction boom that happened in big cities in Ontario, particularly in Toronto, and built up our stock of affordable housing. Without building your stock of affordable housing, and if you don't have any rent control, you put money in people's pockets, but it comes out the other pocket into the landlord's pocket. So federal and provincial governments need to deal with both childcare and affordable housing to be able to get these kids in decent neighborhoods, or actually upgrading the neighborhood and making them learning ready when they hit school. And that's the next part of what we can do to improve health that doesn't necessarily involve giving people more money. Because if I gave you more money, I don't create one more childcare space in the system. It's actually just a progressive version of putting more money into people's pockets. It's like the right-wing version is tax cuts. Let me put more money in your pockets. Sadly, you could design tax cuts that would put more money into poor people's pockets. We don't do that, but you can do tax reform that does that. This is just a different version of saying the solution is putting more money in your pockets. And believe me, I know more money is really needed in many, many households, but it's not the only fix, and it's not the final fix. So if we invested heavily in childcare that actually devoted resources to making kids learning ready, and we targeted it in low-income neighborhoods or to low-income households, we get a huge payback. Pierre Fortin's work from about 2008 showed that for every $100 of daycare subsidy paid out by the Quebec government, we saw a return of $104 for the province and $43 for the federal government. In other words, childcare pays for itself. Why are we not doing it? We have other mechanisms. Another easy fix is putting our money where our mouth is. We have seen time and time again oral care falling by the wayside. It is such a cheap thing to do, to fix people's mouths, reducing further chronic illness, and also making them more employable. These two pictures of Jason, the top and the bottom, you can't see them terribly well. It's a report that we did at the CCPA not long ago, showing that his mouth was like full of rotten teeth, and some dentist upgraded his mouth, and he got a job within 2 months of that picture, and now has a wife and kids. His life got turned around literally because of his smile. We've seen that our per capita spending, the black line here is private spending, going up. It's the same scale. the public spending, you can't see, if I put it on a separate scale, you would see that our public spending is accelerating at a dramatic rate since about 2008, the mid-2000s, and it's because public spending tends to be for First Nations children, for immigrants, people that need acute care, oral health, because they didn't get the primary care that they needed, which is cheap as cheap can be. There's many different ways of doing it, but these are all population and public health approaches. Fluoridation, for example, we just got the story from Calgary that stopped fluoridating its water, and suddenly the incidence of disease has soared. It is one of the cheapest things you can do. So that's basically the message. From your grandmother to you, this is the message that we need, right? The point is, get people healthy, keep them healthy. So the three easy ways that I've mentioned, and I picked three out of the air, but they have huge impacts on housing and early childhood education and oral health. Our alternative federal budget indicates that those three measures alone are worth $5.2 billion. Pick three more. Pick pharmacare, public transit, and post-secondary education. All in, you're at less than $15 billion a year, and both public transit and post-secondary education could be viewed as, in part, a more capital spend, but certainly public transit could be less. Add infrastructure, add clean water, it's still less than you would be spending on what normally, as we cost the basic income approach, we would be spending less money. The argument is, would you be getting better health? Would you reduce health inequities more dramatically by doing this? And more importantly, would you be actually producing more solidarity because more people have access to what the public sector can offer? So I'm just going to reinforce that we need more than income to reduce our costs, to tackle our inequities, our health inequities, and build solidarity. The provision of universal health care was the biggest and is the biggest program of income redistribution in Canada. The second one would be expanding the stock of affordable housing, which would offset what's happening in market prices because of the housing booms in the cities that are most populated, where we have the biggest concentrations of populations of poor Canadians who don't live on reserve. Add your capacity for affordable childcare, for post-secondary and public transit, and you are speaking to the middle class in a way that you don't when you're talking about let's lift the bottom up. And all of these, I would submit to you, are very radical proposals, perhaps more radical than a basic income approach, in the sense that it demarketizes the basics. Instead of just relying on money to providing everything, you're saying that what we can do is take more product out of the market, subsidize the cost, assure people are given the basics. It's a huge debate. We need to have it. So I'm just going to finish off by saying the power of public health approach, as you've heard earlier today, is way beyond public health care. It talks about addressing systemic injustices in the system. It talks about tackling the inequitable distribution of disease, which requires targeted action, and it creates access to services and opportunities that get and keep people healthy, all people, irrespective of their income. And it uses scale to our advantage in a way that money simply can't do. In other words, public health measures save lives 1 million at a time. I'd like to thank Sir Michael Marmot. Where are you? There you are. I'd like to thank you for the work that you've done for so long to keep centered and focused the idea of health for all. And thanks to all of you in this room for your efforts at trying to heal the world. Thank you.